So, Emma, you work in the field of dementia. I wonder if you could tell us a little bit more about what that means in practice. How do you work in dementia?
Yeah, so I'm a clinical psychologist. I've worked in dementia care since I qualified. I've worked right across the dementia care pathway. So I started in memory clinics, and I've worked in care homes, and I currently work on an acute inpatient unit for people with dementia, and into a hospice setting as well. Um, and alongside my clinical work in the NHS, I also work at the University of Hull, and I'm a senior lecturer there in ageing and dementia. And we have a master's programme in dementia for health and social care students who are wanting to know a bit more.
Oh, brilliant! So it's quite a CV, really. You don't look old enough to have done all those things, but anyway. And how did you come to know about the Alexander technique?
So working at the University of Hull, as I mentioned, working with Leslie Glover, and I've heard Leslie talk about her research in the Alexander technique, the Dearest project that she was involved with. So it's something that was sort of on my radar. And then when I was pregnant with my second child, had quite a few difficulties. She was awkward from even before she was born. She was in a very difficult position. I think they called it like a hammock position. She sort of lay sideways throughout to the point of birth, and so it was quite uncomfortable. It's also quite an anxious pregnancy, and I think um, that was it was a very difficult time. And that was when I went myself for Alexander lessons to help me through that time and help me through the pregnancy and the birth as well.
Okay. Yeah, there's an awful lot of people I think that it's helped in various ways, sort of prenatal and antenatal. Yeah.
Definitely, yeah.
Yeah. And when do you know when it was really, or maybe it wasn't a precise moment, it might have been a bit of a process, but when you came to realise that the Alexander technique may have a role in dementia care?
I think, yeah, it's probably a kind of gradual knitting together through lots of discussions, really. There's just so many overlaps in the way that I think about dementia and the care and support that people with dementia need, and the very much kind of an embodied view of dementia and the importance of kind of taking a whole self view of a person with dementia. I think one of the problems we face in clinical practice and in research is that we very much still see dementia as an illness of someone's mind and their brain, and we forget the rest of the person and their body. And so it was lots of conversations that developed, but a real overlap, I think, in the kind of the ethos that fitted for me with what we talk about in dementia care.
Yeah. Okay, great, thanks. And I think Leslie's got some questions for you as well.
Yeah, I was going to come in here. You said, thinking about the care that's available for people with dementia. I wonder if you could say a bit more about that, about the kinds of things that are available and maybe some of the limitations that you see.
Yeah, I mean, obviously the big headline that everyone talks about in dementia and our biggest challenge is that we don't have a cure for dementia, and I very much doubt we ever will. I've got no idea what that would look like. And so that the headline then is quite hopeless, isn't it? The absence of a cure means that people are very frightened about dementia and are kind of, because we're such a hyper cognitive society and we value, cognitive abilities and we value independence, we've got very focused on keeping people independent and keeping their cognition going. And that's where we've developed most of our interventions in dementia care. But having worked in the memory clinic for years, what people are interested in is keeping going, really, their quality of life, how to keep going, how to keep enjoying life, how to keep engaged. And that's much more than just a score on a memory test, isn't it? That's about, the things that are meaningful to someone. And so we've got a lot of interventions that are aimed at improving someone's cognition. But I think we're much less aware of how we can support someone's sense of self, how we keep people going, how we support their resilience. We talk a lot in dementia about the message of prescribed disengagement. So people are actually told to stop doing things, and then people internalize that fear and stigma and those messages, and they stop doing things for themselves because they're very frightened. so we spend a lot of time trying to keep people going and keep people moving in clinical practice, and that is a big gap, really.
And I guess that fits. I know you've done a lot of work with positive psychology approaches, and I guess that kind of whole person actually living well fits with that. Can you say a little bit about that, about the positive psychology?
Yeah, so I mean, for me, positive psychology has been really important in dementia because we have such narratives of loss and of deficit that kind of really dominate, you know, the idea that the person is no longer there, and that just perpetuates all the stigma we have around dementia, doesn't it, and adds to the fear that someone experiences when they're diagnosed. So positive psychology, which is a study of, you know, strengths of resources, of our abilities, our capacity for renewal, which is what you see clinically day to day when you work with people, you know, the strengths that people bring that from, you know, their whole lives and their whole self and their families. It's really looking at what is it that people bring to live well with dementia, what strengths and resources do they have, and in spite of dementia, but also perhaps because of dementia as well, that sometimes dementia sets people on a new path and makes people reevaluate what's important, particularly in the early stages. So yeah, it's been really important to kind of balance the discourses and the ideas around dementia and to enable people to just know that living well is a possibility as well. But it's a fine line, because what we don't want to do is sort of mandate, you know, positives and say dementia is a walk in the park, because obviously it isn't. You know, it's a chronic, progressive and life-limiting illness. But what we mustn't also think is that, you know, dementia is inevitably about suffering, and we need to look at, you know, how do people live well, what helps people, and what can we do, and not just sort of give up on people and think, well, it's inevitable and there's nothing left we can do.
So it sounds like a very different kind of way of thinking about it from a lot of what you hear in the press. So tell me a little bit then about your sense of how you think Alexander technique might be helpful for people with dementia.
I think it's helpful in lots of, it's hard to put into words because I think it's helpful in lots of different ways. I think it's helpful because it meets a person as a person, if that makes sense. So most of the ways that we approach dementia care, we approach the dementia. So it's the dementia that we see first. And I think meeting and connecting with someone as a person, and you know, most people with dementia also live with multiple other chronic health conditions. And at various points in their lives, their dementia might not be the main issue. It might be their arthritis, or it might be the fact that, you know, their wife's also living with cancer. And so seeing the whole person in their life and really starting from that, rather than starting from dementia as the inevitable thing that we think dominates someone's life, I think as just a way of meeting someone, that's really important. So that's one area I think it's really helpful. I think the other is the way the kind of self-care message that comes through. It contradicts a lot of the messages that exist in other dementia interventions. This is not very good putting this into words, but the idea of the kind that the person is still there, I think, and that you can look after yourself is very different from the messages of other people now need to look after you, and you will inevitably be more dependent on other people. I think that's a very clear contrast to some of the messages in dementia care interventions as well. And there's just little parallels all the way through when when you're looking at the dementia literature, you know, just in terms of touch, for example, the importance of touch for people with dementia. There's so much literature on, you know, even in the very later stages of dementia, the use of touch to engage with people, you know, as a person on that level. And that is absolutely missing in most interventions in dementia care, and definitely in a clinical setting where touch becomes just very instrumental, doesn't it? It's about washing and dressing. And so on a very kind of broad level, right the way through to very sort of practical things, there's lots of ripples and parallels where the two knit together, I think.
Wow, that sounds that's very thorough, and certainly, you know, argues the case for investigating Alexander technique in dementia.
I think the biggest challenge that we've talked about, Leslie, that we come across is the idea that because people have a cognitive impairment, they can't learn anything new.
Yeah.
Which just, I mean, isn't true for a start. But this idea that people's cognitive abilities would limit, would mean that they wouldn't be able to learn something. And that's been a kind of stumbling block in a lot of interventions in dementia care. And so people have tended to then work through carers or family members. So, we couldn't help the person with dementia understand this, so we have to educate their family, or we have to offer a 10-week education course for all carers, but we wouldn't invite the person with dementia to that. And so that has precluded people with dementia themselves from a lot of interventions. And I think that's a barrier we've come across as we've talked to other people about the Alexander technique, isn't it, around dementia? Well, how would people learn it? Would they remember it between sessions? And that is a challenge, isn't it? But I think it's what we mean by memory, and this idea that in dementia, suddenly everyone's memory is gone and they can't remember anything. And it's helping people to see that memory isn't one thing, is it? And the kind of felt embodied memories that people have, the emotional memories that people hold on to, are often the strongest, aren't they? So yeah, it doesn't matter what you had for dinner yesterday, that's not important, but the sense you get when you're with someone, you'll remember that the next time you see them. And you might not remember their name, but you'll remember that you feel safe with that person and that you trust them. And there's lots we can do to scaffold and to help people. But I think that's been the biggest barrier I've come across when I've talked to people in terms of the Alexander technique in dementia. But, it's the learning element of it that people worry about, I think.
And it's interesting, isn't it? Because actually it needs a real rethink of what learning is and how learning takes place and what medium it's delivered through, I guess. And being creative in thinking about that and seeing beyond the kind of immediate, obvious limitations seems really important. That's great.
Great. That's absolutely brilliant, Emma. You've been really helpful, informative. I'm sure you would have really, anyone listening to this who doesn't have a background in the Alexander technique or doesn't know much about dementia will find this absolutely fascinating, and it's very uplifting to hear someone talk in this way about dementia.
Thank you.
Thank you.
Thank you.